So in this video, we're going to talk a little bit about atrial fibrillation, or AFib, and basically cover just a little bit about this arrhythmia in the heart. What is it? What are some of the major causes? What effects does AFib have on cardiac output? And based on some of the pathophysiology, what are some of the treatment goals then going to be based on some of the issues that this underlying heart rhythm can cause? So AFib is characterized by this chaotic and unorganized depolarization of the atria, both atria together. And so if you think about the word fibrillation, fibrillation essentially means kind of quivering, right? So just a kind of a fancy term for quivering, right? So we'll say fibrillation equals quivering. Another place where you may have come across the term fibrillation is in a condition called ventricular fibrillation. Ventricular fibrillation, and essentially what happens during this is a what's known as a lethal rhythm. And so if you have a patient on the telemetry monitor, you see something along the lines of this here, where there's really no ventricular activity going on, and there's no synchronized, organized contraction going on, and instead what you have is just a heart muscle that's quivering. And what happens when it quivers like this is it's not able to actually create a forceful contraction, and so the blood's not sent in the direction where it needs to be going. And in this case, with atrial fibrillation, the blood needs to be sent in an organized fashion from the right atrium to the right ventricle, and from the left atrium down to the left ventricle. So typically you have a characteristic S1 and S2 heart sounds, right? You have the lub-dub heart sounds when you auscultate, right? And so essentially you have, with one of these sounds, you have the closing of the AV valves and then the closing of the semilunar valves. And what that is essentially marking is the fact that there is a synchronized expulsion of blood from the atria to the ventricle, and then subsequently from these ventricles out into, number one, the lungs from the right ventricle to pick up oxygenated blood, and also to systemic circulation by the left ventricle. But what happens in AFib is you have these little chaotic, unorganized depolarizations that are going off sporadically and periodically throughout the atria, the upper heart chambers. And so what happens when this occurs is every one of these little depolarizations on its own is not strong enough to result in sending an electrical impulse down to the ventricles to cause a synchronized singular contraction. Instead, this one and this one may get through. The sum of the electrical activity of one AFib beat here and here, or here and here, may become enough to where they can actually get the impulse through to the ventricles. And so what you end up having is a rhythm strip that looks something like this, where the ventricles are not responding to every little sporadic atrial kick, but only some, because only some of them are strong enough to actually get through for the ventricles to then see that. Some of the major causes, number one would be atrial dilation, and this is actually something that occurs quite often with COPD and lung diseases because of the high pressures that the heart has to overcome. That can result in stretching of this tissue. So we know that all cardiac tissue is leaky to some degree, meaning that they all have what's called automaticity, and they're able to discharge synchronously at any given time. Now, some of this tissue is more leaky or able to depolarize more so than other tissue, and those are going to be the reasons why we typically have a nice synchronous contraction coming from the SA node down to the AV node, and then from the AV node leading down into the bundle of His, to the bundle left and right bundle branches, down into the Purkinje fibers, causing one contraction, one contraction, one contraction. So as you have stretch and dilation, that only increases the chances that some of that other tissue up there is able to then discharge spontaneously on its own erratically. Valvular heart disease can lead to this as well. Again, if you have regurgitations that are with valves that are leaky and they're causing backflow and excess, again, that's going to allow these chambers to fill more than they otherwise should and lead to, again, dilation and increased leakiness and discharge in tissues and areas that should not be discharging. Heart attacks, heart failure, coronary artery disease, these can all lead to areas of dead tissue. And so if something dies, namely the tissue around the SA node, which is the pacemaker of the heart, then there's an increased likelihood that some of these other tissues and surrounding areas may decide to go ahead and pick up that job and spontaneously discharge. Hypertension, congenital defects, and then of course cardiac surgeries as well. Anytime we're cutting into tissues, you can irritate cardiac tissue very, very easily. So the effects that this has on cardiac output over here is cardiac output is the product of heart rate, which is how fast the heart is beating, how many times per minute, and stroke volume. So the stroke volume being the amount of blood that is ejected from the heart in a single stroke or one beat. So the sum of this is cardiac output. Well, when you have atrial fibrillation, again, it's disorganized contraction, so it's not a synchronized kick. And so because of this, you lose some of that atrial kick, which is sending the blood down into the ventricles to be expelled to systemic circulation and to the lungs and other places throughout the body. In fact, this can actually result in anywhere from a 10 to 30% decrease in flow to the ventricles. The result that this has is on the end diastolic volume. Remember, you have systolic and diastolic blood pressure. Systolic blood pressure meaning the heart is contracting and sending blood out into circulation. Diastolic meaning the heart is relaxing and actually filling with blood. So if you have decreased volumes in the ventricles, when the heart is relaxing and filling with blood in preparation for that next contraction, because of decreased atrial kick and strength, then that makes sense that overall stroke volume is going to decrease because of this decrease in end diastolic volume. Remember, diastolic meaning diastole, meaning the heart is relaxing. So if it's filling with less blood when it relaxes, less blood is going to be sent out into circulation. Again, stroke volume is decreased. So because of the decrease in atrial kick, the end result is anywhere from a 10 to 30% decrease in total cardiac output. This typically becomes more of a problem at uncontrolled heart rates, greater than 100, 150, 180. And those are going to be situations that we refer to as uncontrolled AFib, where you already have a situation and scenario where the heart is experiencing anywhere from a 10 to 30% decrease in total cardiac output. And now with heart rates approaching 150 to 180 to 200, you have a situation where the heartbeat is so rapid that you combine that rapid heart rate with an impaired ability to fill when the heart is relaxing. With this 10 to 30% decrease in cardiac output that you're already experiencing, that can become very problematic very quickly. So looking at treatment goals are threefold in terms of atrial fibrillation. Again, it's always going to be guided by the physician, but typically we think of treatment goals for atrial fibrillation in terms of what can hurt the patient the quickest. Number one is stroke prevention. As we mentioned, we have little areas of the left and right atrium that are discharging at any given time. It's very chaotic and it's unorganized. So what happens whenever you have multiple depolarizations is the blood is not being sent down in an organized fashion. It then is allowed to pool. So this blood is pooling in the atrium. Anytime blood pools, or you have what's called venous stasis, or hemodynamically the blood is not flowing as it should, you have an increased risk for clots to form. And if these clots are forming in here, there's always the chance that they could be expelled out of the heart. And in the case where they are sent out of the left ventricle through the aorta, then you have potential for a stroke upstream. So number one is stroke prevention. Typically this is going to be depending on risk factors, and again, the doctor will decide this, but the patient may be on aspirin alone. They may be on some other antiplatelets like Plavix, for example, or some more direct anticoagulants, Eliquis and Xarelto, and of course Coumadin, one of the oldest ones. After stroke prevention, the next treatment goal would be rate control, to try to control this heart rate, typically through the use of calcium channel blockers, namely going to be cardizem and verapamil. Those are the two ones that are commonly used for rate control. Typically your nifedipines, nicardipines, amlodipine calcium channel blockers have little to no effect on the heart rate, and therefore cardizem and verapamil are going to be the two common calcium channel blockers. We also have beta blockers, which decrease heart rate, as well as digoxin or lanoxin. Following stroke prevention, rate control, we have rhythm control. So this is typically going to be accomplished by any of the drugs that are listed here. And then also if drug therapy is failed or not indicated, cardioversions and ablations can typically be performed if they're needed. Sotalol is one of those cool drugs that is actually a beta blocker. It ends in LOL, but it's also got some antiarrhythmic properties associated with it. Amiodarone, Tikazin, flecainide. These drugs, typically, if you see your patient is going to be loaded on, they're undergoing a loading protocol, these drugs are going to be requiring serial EKGs, because these antiarrhythmic drugs, some of them have the potential to prolong the QT interval, which can result in some lethal arrhythmias. So oftentimes these patients that are here for drug loading are actually admitted to the hospital for 2 to 3 days so that they can be monitored when these drugs are being started. Cardioversion can be done electrically with the defibrillation pads, and they're essentially delivering a large charge to the heart in an attempt to restore normal sinus rhythm in this case. Typically, if the patient's been in atrial fibrillation without anticoagulation for an extended period of time, they're going to want to anticoagulate these patients before performing any type of cardioversion. And if all else fails, an ablation may be another form of treatment therapy that's possible, where they go in to the electrophysiology lab and actually burn out these little areas once they find the source that the atrial fibrillation may be originating from. So that's it. That's a quick overview of AFib. Hopefully you found this video helpful, and leave us any feedback.